Dr. Keshavi Shah. Now you see it, now you don't. The curious case of subretinal space remodeling and waxing-waning of fluid.
So very good afternoon to everyone. And my presentation is now you see it, now you don't. This meaning will be clear in the next few slides. I'm thankful to VRAG and my team at Netralia for the constant support. Uh, First, we'll delve into the case details. A 23-year-old male patient with history of blunt ocular trauma 4 years prior and presently coming with complaints of diminished vision. He had been operated for lensectomy and vitrectomy with silicone oil tamponade elsewhere 2 months back for lens subluxation and detachment. So this is on the day of presentation. The key findings are patient had BCVA of 6 by 120. Anterior segment findings were suggestive of aphakia with iridocorneal adhesions, but posterior segment showed a redetachment in the inferior part with presence of subretinal fibrotic bands. At this point, our plan of action was to plan for resurgery. But patient came back with sudden loss of vision over the next 2 weeks, and vision had dropped to 6 by 150. At this point, we noted that there was hyphema and severe ciliary congestion. Posterior segment view was hazy and obscured. Now, the plan for resurgery we had to put aside, and we decided to mitigate the acute inflammatory response with intervention of oral and topical steroids along with cycloplegics. So we called the patient for follow-up after 4 weeks time. At this point, we were expecting the hyphema to clear, but along with that, we also noticed that there was disappearance in the amount of the subretinal fluid as well as disappearance of the subretinal band. So now it's no longer visible. The OCT at this time showed diminished subretinal fluid as well as better visual outcome. At this point, we decided that no longer oral steroids were required, and hence we stopped the oral steroids and we started taper of the topical steroids. Patient was called back for follow-up after 4 weeks time, and at this point we were expecting the crisis to be mitigated, but instead now there is rebound. So now we see a new retinal fibrotic band along the infratemporal arcade and increase in the subretinal fluid, which is corresponding with the OCT picture as well. So now we were in a dilemma how to proceed further, whether to go ahead with surgery or to restart steroids. So I'll just quickly summarize the clinical picture. Patient presented with 6 by 120 visual acuity, dropped due to the hyphema. On initiation of steroids, there will be improvement, and then later there is recurrence once the steroids were tapered. And when we look at the sequential fundus photos, we notice that the subretinal gliotic band, which was visible in the first case, it disappears, but it comes back again. So why this case is unusual? Because first of all, there are multiple things which normally we don't see. One is presence of hyphema in the eye already with silicone oil tamponade. Second is regression, and then recurrence of the fibrotic bands as well as the fluids. So as we see it, our hypothesis is that the waxing and waning of the fluid and fibrotic bands had a link with the systemic and topical inflammation modulation. There is dynamic subretinal space remodeling which happens. It's not a simple wound healing response, and all of this is extremely steroid sensitive, as we noted in our case. And
Yeah, thank you, Dr. Kish. Any inputs? What you feel? Any angiography done for this patient? Was it a mitogenous RD or it was exudative?
Sir, initially patient was operated for reg RD. After that, we have not planned a FFA for this patient.
No, because at least if break is closed, can we expect such kind of waxing and waning phenomena like with steroids? Any inputs?
Should they be? Fluorescein might have helped when there was hyphema, or maybe later on once the fluid had resolved and it reappeared. Why it reappeared? Fluorescent
I think
angiography might be optional.
it's just the natural PVR process which is happening slowly. And sometimes just giving the patients long-term steroids, whether topical or systemic, you see the resolution of the PVR and the fluid. So that's why people say that if you see such, beginning of a fixed fold or maybe a small subretinal gliosis, uh, you should not rush into doing a resurgery. You can just give steroids, ask the patient to position, and maybe the process just quietens down, and you can have a persistent fixed fold and an attached retina also. Also, again, the location of the residual fluid or the fixed fold or the PVR, if it's slightly nasally, it's not touching the macula, maybe you can pull along for a longer time before just going into early intervention.
But there was a recurrence after this. When
So
the
this,
steroids.
if you see the subretinal gliosis kept on increasing. First it was only infranasal, then there was a band, then the band came temporally across the macula. So the PVR process, if you see, it's gradually increasing. I mean, if you see this, then there is
No, there was an improvement with steroids, and but there was a lapse.
so that's what I'm
That
saying.
is a
It's
because
it's just if you give high dose steroids, the PVR process is going to come under control. But as soon as you lower it, it's going to flare up. So, I mean, these are very tricky cases, particularly if it's a one-eyed patient. I mean, we would not like to intervene early, and we find out ways how we can maintain a stable, relatively stable, maybe ambulatory vision.
Sir, I would like to ask one question whether we would like to continue the steroids for a long time, even in the post-operative period, would that be required or
Absolutely. I mean, that's what I said. Supposing if it's a one-eyed patient, there is an indolent subretinal gliosis or mild PVR, I would continue, and I like to use difluprednate quite a lot in these patients, just once or twice a day, and keep them long. Just maintain, check the most cases will have a lower IOP rather than higher IOP. So giving them diflucor maybe for 1 or 2 years, I won't hesitate.
oral steroids?
I would not. Would not.
And any role for steroid sparing agents, if not
Not really.
control?
Not really. Once the PVR process has set in, there is not much you can do.
Thank you, sir.
Just to add on, we have been managing this case together. So the last visit, the fourth visit, post redetachment, now tried again for the steroids, but it is not working. Now it is persistent redetachment only. So I have right now counseled for the resurgery. That's it. So far not, ma'am, because it was a case from the beginning as a traumatic cataract with an RD operated elsewhere. So yeah, maybe.
Because there's obviously some indolent inflammation going that you have not put your finger on. Technically, an attached retina will not have PVR. Secondly, we look for when it's not responding clinically, you're going to look for other things, and we know nematodes cause this. A dead nematode can also cause this kind of a picture. The band may not be a band, it could just be fibrin. It could be a protein reaction, that's why it disappears. So, and if you see, the vessels are not normal. There are like beaded vessels in the lower temporal periphery. We are missing something. Yeah, it could be a dead nematode. कहीं कहाँ से स्टील प्रोडक्ट्स में
Even when there was seat.
So there was a perisilicon blood, but everything got resolved with the steroids.